Hello and welcome. It is 8 p.m. UK time, so it is time to start our IVF webinar as we are having another topic to discuss today. I am your host, Caroline, as always, and I'm glad to be back here with Melissa and Dr. Lavy. Hi, Melissa. Hi, Dr. Lavy. How are you feeling today?
We're
Hi,
feeling
Gad.
great. Thank you for having us.
Thank you
It's
for
good to be here.
Yes, and I'm definitely excited to be able to have another webinar with you. So again, thanks for joining our Stronger Together initiative. And also, let me remind everyone that all the events, Stronger Together events, have been brought to you thanks to our ambassadors and partners. You can see all of them right here. So as always, I want to thank them for their constant support as well. And of course, today we do have a very important, very interesting topic, which is LGBT family. And of course, Melissa and Dr. Lavy will start with their presentation. And after that, it will be time for your questions. So you can actually put all the questions in the chat section during our presentation, and actually Dr. Lavy and Melissa will be answering them for you. So don't hesitate. If you have any questions, just go ahead and type those in as well. And let me just mention that Dr. Lavy is medical director and founder of New England Fertility, and Melissa is also cooperating. She is a lawyer and she's cooperating with New England Fertility. It's good to have you, as I've mentioned. And well, are you ready to start with your presentation?
We're ready.
Excellent. Go ahead then.
So, so first of all, I'd like to thank Caroline for organizing this, and as usual, very prompt and very efficient. And I'd also like to emphasize that I would love for this to be more of an exchange. So please feel free to interrupt us at any point with questions. Of course, we'll be able to answer questions at the end, but I mean, it would be great if you can interrupt us with questions when we move from topic to topic. So my name is Gad Lavy, Dr. Lavy. I'm the medical director of the New England Fertility Institute. We're located in Connecticut. The city is called Stamford. Ours is a fertility IVF clinic, but over the past few years, we've turned our focus into what we call third-party reproduction, which basically involves egg donation and surrogacy. And of course, just by the nature of things, and just because I felt from the very beginning, with all the advancement in reproductive technology, I felt that this was an opportunity to allow all kinds of families to be created. So we're talking about heterosexual couples and same-sex couples, and we're talking about singles, male, female. So that of course, sort of bodes very well with the third-party reproduction. So we've been working from the very start with the LGBT community very closely. We're connected to the centers in New York City, but also with couples from different countries. And as Melissa will touch on, it's been really a challenge for LGBT couples to build families, just because the laws in most countries are not very favorable. So, and we'll touch on that when we continue the presentation, because we strongly feel that the U.S. is the most friendly, easiest, and most conducive to doing these procedures. So, and of course, and as you'll see, in order to do these procedures, we work as a team. And the team involves not just the clinic, but also the surrogacy agency, the law office, in most cases, an egg donor, and almost in all cases, a surrogate. And finally, you are also part of the team. So we look at it as in a sort of the big picture, making sure everyone understands and everyone is on the same page. So I'm going to let Melissa introduce herself, and then we can start.
Sure. So my name is Melissa Brisman, and I've been working with New England Fertility for probably about 20 plus years. I own a surrogacy agency, Reproductive Possibilities, which helps all kinds of families, same-sex couples, both male and female, heterosexual couples, and single people to have babies. We've had over 2,500 births since we were founded 20 years ago. And that's a strong part of our LGBT is the same-sex male couples having a carrier. I also have a law firm, and the law firm does a lot of legal work for different same-sex couples, whether that be adoptions, sperm donation agreements, egg donation agreements, embryo donation. I've written a lot of laws in the United States, both for different states, New York and New Jersey, and actually in 2010, I was a part of the team for the Taiwanese government to write the surrogacy law for Taiwan. So I'm pretty familiar with international couples. We have a large team of 20 that can help you through this process. And hopefully we're going to explain to you today a little bit more and make it a little bit easier for LGBT couples.
So thank you, Melissa. And for me, it's been from the very start. We've been collaborating for many years, and it's been an honor to work with Melissa just because of her background and her expertise, and also because she leads an amazing team of people who basically are friendly and helpful and knowledgeable. So I'd like to start maybe just to outline what we're actually talking about. And of course, with each one of those, I mean, we can spend a couple of hours just explaining the details. So what I'll do, I'm just going to outline the different things, and then maybe focus on the processes that we actually do in the U.S. that for most part you cannot do elsewhere. So basically, we always look at it as basically male and female couples. So for same-sex male couples, and this is actually, I'd say, the largest group that we take care of here, because for those people, the options are very limited in other parts of the world. And for male couples, basically, they require to have a baby, they require an egg donor. They require a surrogate, somebody to carry the pregnancy. And then in most cases, they create embryos for both partners, sometimes for one, and basically then decide who is going to be the biological father first, so how many children they want to have, and so forth. So as I said, this is sort of the main processes that we do in the U.S. Of course, we see many American same-sex female couples. For females, it's generally easier because they always have the option of having an insemination, which doesn't involve all the assisted reproductive technology and all the high-end technology. But in some cases, we use egg donors. In some cases, we do what we call reciprocal IVF, where the eggs come from one partner and they're fertilized with donor sperm and go into the other partner. And in some cases, we do surrogacy. But as I said, we don't see too many same-sex female couples coming to the U.S. to do these procedures. And similarly for single men and single women, we do see quite a few single men that are ready to build a family through assisted reproduction. In those cases, they will use an egg donor, they will use a surrogate, and usually use their own sperm. For single females, again, mostly if they're in the right age and they have a functioning uterus, they usually will just do an insemination with donor sperm. But again, we see many women that come from abroad for egg donation, with them carrying the pregnancy, because the laws in the countries that they come from are restrictive, either in not allowing them to do it as single women, or not allowing egg donation in general, or not giving enough information about the donors to make them comfortable. And of course, in some cases, they can't carry, and then they use a surrogate. Melissa, would you like to?
Sure. Yes. Thank you. So basically, for any option that you're going to be doing with a third party, whether you're heterosexual or same sex, you're going to want to make sure that legally, especially in the United States, that you have everything done properly, so that the rights that you expect to have to that child and the responsibilities are as you expected. So for same-sex male couples, they will need a little bit more legal help than same-sex female couples. And this is very involved for some cases and very simple for others. So in the United States, same-sex couples can get married everywhere. So basically, if you're married, then a child from the marriage born inside the marriage is going to be a child of both of you. But however, if you're a same-sex male couple, you are going to need a contract with your surrogate. And on that contract, you should have lawyers on both sides, because with what we call a gestational surrogate, you can actually terminate her rights prior to birth, which you can't do in some states or countries in the UK. So you want to make sure in the US you have a surrogate from what we call a surrogate-friendly state, and the contract is properly drawn up. The same thing is going to go from an egg donor or if you have a sperm donor. Now, most likely with the same-sex male couple, you're not going to have a sperm donor, but sperm from one of the partners. So you're going to want to see contracts with all the third parties, whether it's egg donor, sperm donor, surrogate, and lawyers on both sides. Now, if you're unmarried, there are going to be different contracts that you might have to do, because you're not going to own any eggs that you get or any sperm that you get jointly. So it becomes a little bit more complicated for an unmarried couple. In addition, when you have a same-sex male couple or anybody using a surrogate, you have to get what we call a parentage order. So basically, what does that mean? That means that when that baby is born in U.S. soil, yes, it's a U.S. citizen, but it belongs to the woman who gives birth, unless there is something filed with the court to make sure that that woman isn't named as the mother. So if you have a gestational surrogate, you file papers in what's called a parentage order or parentage action, so that the court will deem the proper parents to be parents of the baby and placed on the birth certificate. So we need an attorney to do that between 3 and 5 months of pregnancy. And you also want to make sure, because there are 50 states, there are differing state laws, and because egg donor, surrogate, and the parents can live in various places, you need to make sure that your attorney can navigate all these things. Basically, the thing to remember is you want to get an experienced reproductive attorney to help you, what's usually fairly simple, but can become very complicated if you have poor advice. So we want to make sure we have contracts in place that delineate the rights and responsibilities and make sure we're following the law. But other than that, the law is pretty established in the United States.
So thank you, Melissa. So essentially, I mean, you know, what we do as the clinic and the IVF, which I'll go over in a minute, is pretty straightforward. The technology has been around for a while. But again, for each case is a little bit different. Each journey is a little bit different. Each country is a little bit different. So you want to make sure that you have the legal part covered completely. Now, what I'd like to start with is talk about basically what stands in the center of this whole process in the medical side is the in vitro fertilization. And again, we will focus from now on mostly on egg donation and surrogacy, mostly for same-sex male couples or for single men. But of course, it can be applicable, as I showed earlier, for women as well. So in the center of all this, of all we do, the medical side is in vitro fertilization, IVF. And IVF is a fairly young technology. That the first baby was born in the late 1970s in the UK. But since the IVF came on the scene, it basically revolutionized the treatment of fertility or infertility. And what started basically as a sort of almost like a science fiction, like an experiment, has become a well established technology. You know, there was basically almost a year between the first and the second baby, but on the recent count, there are almost 10 million IVF babies in the world. So clearly, it's definitely mainstream. And the thing is that, you know, the procedures have improved quite a bit over the years, and giving us much higher success than they did at the beginning. And with higher success, of course, we have higher utilization. So the procedures themselves are no longer considered experimental. And just without getting into too much detail, I mean, the IVF process, it basically involves the following. So we remove the eggs from the ovary after the woman has been taking medication. And this is true whether it's your own eggs or an egg donor. After about 2 weeks of treatment, the eggs are harvested. They're removed from the ovary with a very simple procedure. Again, when we first started doing IVF, the process was fairly complicated. It was a real surgical procedure in the operating room with anesthesia. And nowadays, it's a 10-minute office procedure with a little bit of sedation. So not only it's more comfortable to offer it to people who are trying to get pregnant, but we can also ask the young women, egg donors, to go through it, knowing that it's not that difficult and has very few, if any, complications. So the eggs are harvested and then fertilized with sperm, and depending on the situation, whether it's your sperm or donor sperm, and then we grow the embryos in the laboratory. And I'll get into more details in a second. But that allows us to essentially evaluate the embryos, because it's really, really important that when a time comes to use those embryos, we make sure that we pick the very best embryo. And that allows us then to put back a single embryo and avoid the risk associated with multiple pregnancy. So these are the steps of the IVF. And again, there's been tremendous improvement in these areas. So we have better medications, safer medications. We are able to grow the embryo, as you see here, to what we call a blastocyst, which is 5 or 6 days, and essentially being able to determine the viability that way. We're able to inject the sperm directly into the egg, as you see here on the left, which essentially ensures fertilization of the eggs, even if the sperm count or the sperm motility or morphology is not optimal. We've made tremendous strides in what we call cryopreservation, or freezing of embryos, freezing of sperm, freezing of eggs, and allows us essentially to preserve the embryos without any loss of viability. And I'll show you in a second, when we put the whole process together, why this is so important. And finally, and this has been probably the latest development in the IVF world, is the fact that we can do genetic testing of the embryos without damaging the embryos. In other words, we can actually determine if the embryo is genetically normal, genetically balanced, before we put the embryo into the uterus. And that's huge. And what you see here on the bottom on the left is there is a big difference in the success if you pick an embryo to put back that's been tested versus an embryo that hasn't been tested. And again, that contributes to the higher success and contributes to our ability to avoid multiple births. So as I said before, and for me, this is, one of the huge advancement in the reproductive medicine is that as the treatments became more successful, as they become more simple, it allows basically more access to treatment to different types of people. So for example, we treat individuals, we treat couples, we treat heterosexual, we treat gay couples, and basically with success the way it is now. I mean, you never say never. You never say there's a guarantee, but there's almost a guarantee that pretty much everyone, if they're willing to take advantage of all the technology that's out there, it's pretty much guaranteed that you can walk away with a baby. So it may not happen on the first try, may happen on the second try, but it's very unlikely that you walk away empty-handed. And of course, we always have this in our minds that our goal is to have a healthy baby, and that's why we make sure that all the procedures are safe. We try as much as we can to avoid multiple pregnancy, because that carries a risk of premature birth or preterm birth and the complications there are associated with that. As I said at the beginning, this is basically a team effort. So there's not one individual, not one group. It's all of us together. And to do the process in the U.S., to do the egg donation, surrogacy, IVF in the U.S., you have to work with a clinic. And the clinic will basically do the clinical parts, and I will show you in a second. And then you have to use an agency, the surrogacy agency, which will find you the surrogate and help you with the legal arrangements. So in the team, of course, are the parents, is the egg donor, the surrogate, the agency, the clinical team, the legal team, and the financial team.
And Dr. Lavy, I see we have a few questions also after this slide, so.
Yes,
maybe.
So before we move, I will. So essentially, our goal when we do it, when we work with Melissa's agency, is to try to remove as much of the stress as possible, as much of the technical things that you don't really need to be involved with, and allow you to focus on what we call the journey. And really truly is a journey. And allowing you to basically focus on the important decision in the process, picking your donor, picking the surrogate, picking who's going to be the biological father, and not have to deal with the technical issues. Melissa, if you want to comment.
Sure. I think really the most important part about embarking on any third-party arrangement is that you make sure that you do your research in advance. So you want to make sure that you're going both to see myself and Dr. Lavy at the same time, because one of the things in this process is, because it takes a whole team, it does take some time to get ready. And just like it may take a few months for a heterosexual couple to get pregnant, it is going to take you, several months to get yourself organized. So that while taking a team, you also have to take your time. So you want to go to the agency to help pick out the best egg donor or the best surrogate for you. And you want to give us some time to find that appropriate person for you. And also to make sure that legally we have everything set. So for instance, if you live in the UK, you need to get a certain parental order to go back and get citizenship for your child in the UK. So we want to make sure that we have all the current elements of UK law intertwined with US law, so you can bring your baby home pretty easily. And all of those details will be individualized for your case.
So before we move on, I see there is some question. I think the first question is for Melissa. Caroline, you want to put it up?
Yes, of course. Let me just show you here, of course, the first question. So, can a male non-donor claim some kind of parental rights even if two females are married at the time of conception? More case law on this issue arising in UK, even if a regulated clinic is used.
So, I'm an attorney based in the US, so I'm going to answer this question as if you are doing this under US law. But yes, a known donor can claim some kind of parental rights, even if the couple is married. if you don't follow the state law. So there are two issues with this. Most states, not every state, but most states require that your artificial insemination does not involve sexual intercourse. So in most states, if the male donor has sexual intercourse to make the female pregnant, he cannot claim that he was a donor. So that can be an issue. Number two, some states like New Jersey require that the procedure is done by a physician, so that if it is not done in a physician's office or by a physician making house calls, which is very unusual these days, so if it's not done in a physician's office, then that can also make the fact that you used a donor unenforceable. We always like to have, if there's a known donor, a contract to solidify the claim. But so if it's done in a doctor's office, in most states, you're pretty clear, but you want to follow the state law to make sure you are. Some states have parental estoppel laws, which basically means that if you enter into a known donor arrangement, but then you act like a father by paying child support, having the kid visit with you, and the kid is 5 years old and you've done everything as if you were the child's father, it may be that you are going to be ruled to be the child's father. So you want to make sure you have a good knowledge of the law in the state in which this is done.
All right, excellent. Thank you so much for your question, and of course, Melissa, for helping with this. Well, there's another question, so I guess we can answer it right away as well. Yes?
Yes. Sure.
Excellent. Sure. The question is, so can both partners be biologically related to the babies? Can my partner and I mix our eggs to become pregnant?
So yeah, this is a good question. But basically, in order to have a baby, we need one egg and one sperm. So in other words, it's not possible to mix. So sometimes, you know, when you can actually mix the eggs and add the sperm, and then you create embryos and you don't really know who's who. We generally don't do that. I don't recommend it, but it's certainly possible. But in most cases, we know exactly whose eggs we're using and whose sperm we're using, and therefore we know who is the biological father and biological mother for that baby.
But Dr. Lavy, I think what they're asking is, could you fuse two eggs to become one? And I think the answer to that is currently no, correct?
Yes, exactly. Yes, that's what I was trying to say. I mean, it's basically one egg, one sperm, and you make a baby. There's no at the moment, at least, there's no other way.
Mm-hmm. Okay, excellent. Thank you so much for this, indeed, as well. And there is a thank you here from the patient as well. Okay, and well, now I just want to remind everyone that you can go ahead and type those questions in, and now we will go back to the presentation right here.
Okay, so essentially what this slide depicts is what each entity will do for you in this process of egg donation and surrogacy and IVF. So I'll explain what we do, and then Melissa can explain her part. For the fertility clinic, of course, you know, we do the medical process, the IVF process. And in addition to that, we also do the screening, the medical screening and the psychological screening. And we do that for actually everyone involved. So in the case of an egg donor, we do a screening of the donor, which I'll review in a minute. And we do the same for the surrogate. We also, our clinic we have our own pool of egg donors. These are young women that we recruit that essentially go through very extensive evaluation to be donors. So when you do the process with us, we will basically find you the egg donor. Melissa's agency will find you the surrogate, and then we will put the process together. We'll get the sperm, make the embryos, and impregnate the surrogate. Melissa.
Yeah, so our office the first step will be to help you find the surrogate, and in that process of that step, we will also do the non-medical clearance on the surrogate. So her criminal background check on her and her partner, a home study to make sure it's a safe place to have a pregnancy. And we will also gather the medical records and any other data for Dr. Lavy that he needs. We're also going to be preparing the legal contract as we represent the intended parents, and get it over to the surrogate and her attorney. As described before, we're going to have to help you get your name on the birth certificate. That's called a parentage or a pre-birth parentage order. So that will be something that our office will help you with. Also, a big part of this process is finances. People will need estimates of how much money, when they need it. And we really try to keep you out of the financial arrangement with your carrier. So we have an escrow account, and that will be used to pay the carrier and to pay all the bills on her behalf, of course, with your permission. But it keeps you out of having to deal directly with anybody other than our office regarding finances. And of course, you will have a coordinator in our office, and that will be your support person who will check in with you and your carrier every week and make sure that, you know, everyone's traveling where they need to, that they're safe, that they feel good, that they're getting the medical records. If you want to Skype or Zoom or participate from abroad in any pregnancy appointments, that you're able to do so, and you're getting all the information you need. So that's, we manage, we're like your general contractor managing your entire process for you.
And just to add to that, so essentially we have a similar structure as Melissa described. So when you're working with our clinic, you'll be assigned a case manager, or we call them coordinators, who will be in charge of basically making sure that the process runs smoothly. They'll be your point of contact. They'll know your case. They'll be in touch with you. They'll be in touch with the donor, with the surrogate, and with their counterpart at the surrogacy agency. So that way, as I said, I mean, it allows you then to not to worry about the technical details and focus more on the important decision, on the process. And even though it is stressful and is a big step, at some point it can be a fun experience, a good experience. I've already mentioned that, and I'd like to say a few words, and also have Melissa comment. Is the fact that we believe that doing this process in the U.S. has many advantages compared to other countries. We both have worked in other countries. I mean, I actually was involved in surrogacy in India and Eastern Europe, and I know that with that experience, that the way we manage, the way we handle the process here is superior in many ways. So the legal climate, I'll let Melissa explain, is definitely favorable. The IVF technology in the U.S. is still, even though there have been advancements elsewhere, we still have the highest success of the procedures in the world. We have access to genetic screening of embryos, and essentially that, as I said before, allows you to increase the chances of success, and even, I didn't mention, but allows you also to identify the gender of the embryo. And if you have a desire to use one gender or the other, it's very easy to do so. The other thing, and I mentioned before that many people actually come, even if they only need an egg donor, come to the U.S. because of the fact that you can get unlimited information on the donors. In many countries, in Europe, Spain, for example, you can do egg donation, but the information you get about the donor is minimal. So in the U.S., you essentially can have as much information as you want about both the egg donor and the surrogate. Different than other countries, we encourage, even though we don't require, that you have a relationship with your surrogate. So you basically follow her along with the pregnancy, and you're in close connection with her. I think for many people, that's a really, really important part of the process, of the experience. And also, doing this process where you give up so much control is hard enough. and especially doing it in another country overseas is really difficult. And having that connection, having that interaction, alleviates a lot of that anxiety. And finally, just from my experience working abroad, definitely in some countries, the standard of living, the health system in the U.S. is superior in many ways. And that ensures, especially in the case of the surrogates, but also in the case of the egg donors, in ensuring that you get basically someone who carries your baby, who's healthy, well nourished, well taken care of. And of course, for the donors, the same. They're healthy, they're in good physical condition, and therefore the eggs that they produce are better. Melissa.
So, yeah, so also the legal climate here is very exacting. The statutes will tell you exactly what to do for both surrogacy, egg donation. We will know how to make you a parent. For instance, surrogacy is much different here than in the UK. In the UK, even if it's a heterosexual couple using their own genetics, the gestational carrier will have 6 weeks to keep the baby if she wants to. In the US and most states, that's not the case. Most cases, the contract will be enforceable for custody and parentage determination. So that's important as well. For egg donation as well, you have lots of choices. You can have what we call known donors or what we call not identified donors. So we have less restrictions in the legal climate. We don't have laws about sex selection, who can do it, who cannot, what are the reasons. We have the ability to do abortions in many states up until 28 weeks. We have a lot of advantages legally in terms of who can use a surrogate. Yes, it's preferable, obviously, to have a medical reason or be a same-sex male couple, but it is permitted if you don't have a medical reason, or if you don't want to carry, or if you just want to do PGT or genetic testing just because you want to, or just because you want a boy. All of these things can be accomplished with a lot more ease in the US.
Thank you. So now let's just go to more sort of the technical side, and just to show you in a diagram, in a schematic form, how the process is done, how the IVF process is performed. Essentially, as you can see here, we divide the process into two parts. The first part is creating the embryos. So for that, we need the sperm and the egg. So usually, for a same-sex male couple, is having an egg donor and using their own sperm. The donor goes on medications, usually for about 2 weeks, to produce somewhere in the neighborhood of 20 eggs. After about 2 weeks of medication, the eggs are ready, they're harvested. As I said, a fairly minor procedure, we call it the egg retrieval. And these are the eggs in the petri dish, and this is the sperm. So typically for men, we split the eggs and fertilize half with one partner and the other half with the other partner. So that way we have two sets of embryos which we track and follow the development over the course of 5 or 6 days. After 5 or 6 days, the embryo will reach what is called a blastocyst. If you remember from biology, the blastocyst is the final stage of the development of the embryo. Beyond that point, the embryo actually has to attach itself to the uterus to continue growing. Also, if you can see here in this diagram, when the blastocyst has about close to 200 cells, so the egg and the sperm unite and create a one-celled embryo, and within 5 or 6 days we have 200 cells, and we have an embryo that is what we call has differentiated. You can see there's two distinct parts. One of the will become the baby, and the other will become the placenta. And that allows us then to safely remove a few cells from the placental part, from the embryo, and do the PGS, the genetic screening. And the genetic screening essentially looks for the number of chromosomes to make sure that they're balanced. So we can eliminate things like Down syndrome or any conditions that where the chromosomes are not balanced, which usually will either lead to the lack of implantation, lack of success, or can lead to a miscarriage. So by eliminating those embryos and not using those embryos, you can expect a much higher success for each embryo that you transfer. And as I said, as long as, once you're counting the chromosomes, it's very easy to be able to identify the gender. So you know for the embryos which is male, which is female. So at the end of this process, of the first step, which takes about 1 month, we basically have the embryos frozen. So once the cells are removed, the embryo is frozen. And we get the report, which tells us, how many embryos we have, how many of them are normal, how many of them are male, and how many are female. So at the end of this process, for most people, we end up with somewhere between 6 and 8 genetically normal embryos. And that means that if you're splitting the eggs, then each one of you has 3 or 4 genetically normal embryos. And that's usually more than enough to have 1 child for each partner. Because if you look here at the success, for 1 embryo, it's somewhere between 70 and 80% chance of having a success. As I said, we usually only use 1 embryo. But if we do 2 embryos, the chances of having a pregnancy, whether it's a singleton or a twins, is over 90%. And most of those are twins. Now, the second part of the process, which also takes about a month, is to essentially have the surrogate. So the surrogate goes through the screening, which I'll describe in just a minute. We make sure that she's a good surrogate. We prepare her with some hormones to make sure that she's ready to receive the embryo. And that takes about 3 weeks. And then when everything is in place, we will take, like I said, 1 embryo from the freezer and put it in her uterus. I said many times so far that we prefer to do a single embryo. And of course, it comes up very often, especially with male couples, that they would like to transfer 2 embryos, 1 for each partner, and essentially have that way a sort of an instant family. And there's certain different considerations, and not the least of them is the financial, because it's definitely less expensive to have twins and have a child for each partner when you do it in 1 round. But again, you have to really, really consider the risk. But if after all of that you decide that you do want to have twins, so then we of course have to find a surrogate that is not only willing, but also based on her history, able to carry twins. So this is basically the process. So it takes 1 month to make the embryos, and it takes another month to put the embryos in and find out if it works. And the rest of the time is of course spent getting everything ready, finding the donor, finding the surrogate, doing all the testing to make sure that everything is right before we begin. So Melissa, if you want to tell us a little bit about the sort of the timeline of what to expect.
Yeah, absolutely. So that is really the biggest issue that people come with when they're doing a carrier. You should expect about 6 months to find your carrier. Could you find your carrier in 2 months? Absolutely. Could you take 8 months? Absolutely. It just depends. If you are incredibly easygoing about everything about your carrier, it will happen quicker. But usually this is a very important process for most people. And it takes them 4 to 6 months to select the person that they want. Usually it's about 1.5 years from the time you start to the time that you take that baby back to your home country. If you are living abroad, as most people who are on this webinar are, I would tell you to plan to be in the United States during a non-COVID time for about 2 to 3 weeks. Now people are here a little bit longer because passports are taking a little longer to issue and travel restrictions. But in general, you're here 2 to 4 weeks after birth until you can fly back to your home country If you do have twins, I like you to plan a little longer, because if your baby is small or in the NICU, then you're going to take a little bit longer to get back to your home country during this process. Obviously, the pregnancy itself is 9 months, so about 9 months to get ready. That's why we say a year and a half for the process.
And of course, it's really important to have, to adjust the expectations before you start. So we will spend time talking about specifically your case and how long it's going to take, and based on your requirements. So that's going to lead us to the next topic, is the egg donors, whether it'd be easy for you to find a donor or whether it's going to be a little bit more difficult. So let's move on to the egg donor. So we're going to talk about the egg donors, the eggs. We're going to talk about the surrogate, the uterus, and a few words about the sperm. So for the egg donors, of course, we're looking for women who are healthy. We're looking for women who have good eggs. So there's sort of all these criteria are essentially, required, and just to be able to be considered to be a donor. So we only take women who are young, no older than 30, but mostly are mid-20s. They have to be physically and mentally healthy, non-smokers, no drug, no significant family history, good ovarian function, and also very important that they're psychologically in the right place. They're doing it for what we consider to be the right reason. And someone who we believe is going to be compliant and motivated to go through the process. I'm listing here, again, just that, the idea is that the donors go through very, very extensive screening. We end up eliminating most of them, over 90% of the applicants, because we're looking for a very specific, very special person. So they go through the medical evaluation, they go through genetic evaluation. So we create a 3-generation family tree. And also we do testing for recessive diseases, what's called carrier screening. And we will test both the egg donor and whoever is the sperm donor for the same conditions to make sure that there's no risk for the baby to have a disease. So we spend also quite a bit of time on the psychological clearance. As I said, we do a standardized written test, and also have them interview with a counselor to make sure that they're mentally healthy, they're motivated. And for us, it's really, really important when we're dealing with the donors to make sure that they understand fully what they're getting themselves into, because it is a big deal for someone who is in their 20s. And we want to make sure that, or at least minimize the possibility that, 5 or 10 years down the road, they'll say, oh my God, what did I do? I shouldn't have done that. Melissa can speak about the legal clearance or the legal considerations for the egg donors.
So legally, we want to make sure not only that the donor has given up the right to claim parentage to the resulting child, but we want a lot of other things in the contract as well that people don't really realize. Right now in the US, you have a lot of at-home DNA kits by companies like 23andMe, in which people send in some of their genetic material and then are able to connect to other people who might have some of their genetic material as well. In other words, be a relative. So even if the donor hasn't submitted, you could find the donor's sister or some other relative through your child who's from an egg donor taking one of these kits. So we want to make sure that the donor doesn't seek out your child through an at-home DNA kit, doesn't do anything to interfere with your parental rights. But that is a risk that everybody should know, because if the child does it and contacts the donor, their child isn't a party to your contract. So we do go over that a lot now because it's a big issue. Use of social media, complications. You want to make sure if she has any complications in the egg donor procedure, even though it's rare, that it is not your responsibility after a certain period of time. We want to make sure the donor has health insurance, and if not, we want to buy her a specialized policy. So we go over liability, we go over contact, we go over confidentiality, we go over if there is going to be contact later on for medical issues on either side, if the donor discovers something or if you discover something in your child, what kind of communication and through who. So there are a lot of things that we talk about that we would put in these agreements that you may not think of.
Thank you. So we already covered that, and I'm just going to skip on this over this slide. And just basically, and again, just 2 words about this, is there's different things to consider when you pick your donor. But actually, the most important is for you to sit down and think, what your requirements are. What would be an appropriate donor for you, and we will help you with that. But once you do, we basically have to consider all these other things. For example, Melissa mentioned, because the law in the US allows you to actually connect with a donor, it's possible there are some couples that prefer to actually meet their donor, either in person, on video, through email, or even have the ability to, down the road in the future, to connect with her in the event that the child is interested in knowing who their biological mother is. So that's one thing that you need to tell us. Not all the donors agree to be known, but if you go to them and said, I have this couple, they want to meet with you, they want to talk to you on the phone, in most cases, the donor will agree. So that's really, really important. As far as, the donors, some of our donors have already donated previously. Some are doing it for the first time. As far as the success, it makes no difference. People often ask about how many times a donor can donate, and of course, we're very concerned about the donor's eggs, or too many of those, the eggs being out there in the world. So we try to limit the number of donations, and I certainly try to limit the number of donations that our donors do to certain countries or states or geographical areas, to try to avoid, obviously, sibling meeting each other without knowing. One thing that I'll talk about just briefly is the fact that you basically have a choice of either using what we call the fresh eggs. This is a donor that you pick, goes through the process, we harvest the eggs and we create the embryos, as opposed to frozen eggs, which is a donor that has already been through the process. The eggs have been harvested and frozen. And we don't have much time to go over this, but essentially the technology of freezing, of cryopreservation, is such that at the present, there is no difference as far as viability, success between fresh and frozen eggs. So basically, what do you do when you're ready to be matched with a donor? So we will spend some time with you and essentially establish your criteria. You tell us what the donor should look like, ethnic background, education, whatever is important to you is important. So, and based on your list, we can tell you, how easy or difficult it will be to find the right donor. I can usually tell very quickly by just looking at the list if you're going to find a donor within immediately or it's going to take you forever. And then we try to basically work with those criteria and try to find a donor. As I said, we have our own database, about 100 donors. It's not huge. I mean, it's because you only need one donor, but it has to be the right one. For some people, it takes going out to other resources, other databases, other pools to find the right person, and that's something that we will help you with. And then finally, you find a donor. For most couples, I would say it takes about 1 to 2 months to find the right donor. So again, just to summarize, these are the donors that we recruit, healthy with good eggs. This is the screening that we do, and this is how we match you with the right donor. We're going to move on to the surrogacy portion. And and navigate this. And now let Melissa tell us a little bit about the surrogates and what we're looking for in a surrogate, and how you find the right surrogate. And Melissa.
Oh, sorry. So basically, if you want to find, the right surrogate, I want to basically know what it is you're looking for. The biggest thing in finding a surrogate from a non-health perspective, in other words, we're always going to follow what Dr. Lavy gives us for criteria. But the most important thing from a perspective of matching is, do you want the carrier to terminate if there's something wrong? So in the United States, abortions are allowed, unlike in some countries, and usually they're allowed up to somewhere between 20 and 28 weeks, depending on the state, and the surrogate can always travel out of state for the termination procedure. And although we don't need a lot of them, they do come up. And if you are going to want that, we want to make sure that you have a surrogate who's comfortable with having a termination at the time that you may request it. We also want to ask about, do you want a carrier who is going to be more friendly, or do you want more of a business type relationship where you check in less often? Do you want to be Zoom or Skype into doctor's appointments, or do you just want to get the information afterwards? Are you want to be present in the birthing room, which is okay, but we have to make sure the hospital allows it and the carrier also is comfortable with that. We want to know about things like pumping her breast milk. Do you want that? We don't support breastfeeding, as that can promote bonding with the baby. There are other more subtle things that we talk about. Are you concerned about diet and organic food and hair dye, or are you more easygoing on those things? So those are all things that I'm going to want to know. Do you care about the race of the carrier? It doesn't matter. Your race or religion doesn't matter to us. Neither does the carrier. But if you have preferences, we want to know about those.
And thank you. And as far as the medical aspects, probably the most important is that we only take women who have children. And from the medical part is the fact that we then can look at their pregnancies, we look at the deliveries, make sure that they were uncomplicated. We review their records very carefully. Actually, that's one of the criteria, that you have to be able to provide the medical records in order to become a surrogate. And we also connect with their doctor before we give our final approval. So this is the doctor that usually delivered her children, is familiar with her health history. So even if there's things that are not evident or obvious from the records, we make sure that we've covered that. So they will need to provide us with a letter of clearance from their doctor. Now, when you presented with a carrier, with a surrogate, some people have very sort of strong opinions of what they want or don't want. But from a medical perspective, few things matter other than the fact that the surrogate is healthy and had good pregnancies. So, for example, her age is not really that important. People worry, for example, about a surrogate that had a cesarean section. Typically, it doesn't matter as long as the cesarean section was uncomplicated. And again, we confirmed that with her doctor. Even if she had one or even two or sometimes three, her chances of having a successful, uncomplicated pregnancy and birth are still very, very good. Of course, we make sure that general health issues. Doesn't smoke. She's in general good health. Has a reasonably normal BMI. Melissa mentioned the fact that the agency will do a home visit just to check her house, see how she lives, how she takes care of herself, her children, and of course we make sure that she's mentally intact, similar to the donor, but different because obviously she's getting herself into a different situation. And we make sure that she's not just mentally healthy, but she's also mentally prepared to go through this process. Because as much as it's a big step for you, it's also a very big step for them, because they will be pregnant and with everything that's involved, and then at the end of the pregnancy, they will hand over the baby. So, of course, this is not for everyone, and we want to make sure that we find the women that are able to do it and are not going to have any issues with that. And it sort of brings us to the fact that most of these women are amazing. I think I always tell the surrogates that they have a place reserved in heaven because they're doing an amazing thing. And even though they get paid and essentially a job that they take on, uh, there is a very large altruistic component to what they do. Uh, they enjoy being pregnant. They enjoy actually being able to allow other children, other people to have children. So it's an amazing thing, and it's something that's a little bit difficult to describe until you actually sit in the room with the surrogate and talk to her. So again, we make sure that on the medical side, the psychological side, there's no problems. We make sure that she fully understands what she is required to do, because again, it's a job, and there's certain things that we must insist that they do. Go to the doctor on schedule, take the medications that are required. So again, it's similar to the donor. We screen out, I would say, most of the applicants, and only pick the very few that are, the best of the best. So just again, a very quick, just to show you the flow, how it works. So essentially, the agency will find you the surrogate. As soon as they find the surrogate, they will collect the medical records and send it to us for review. We review the records. If everything looks good, we invite the surrogate to come to the clinic. The surrogate will usually travel to the clinic. This is normal times. Now with the COVID, we are doing some of these remotely, but she will come to us and complete her screening. The medical screening, blood work, ultrasound, the psychological evaluation. We sit down with them and train them on what they need to do. And at the end of that visit, we know if this is going to work out, if it's going to be a good match. We, of course, invite the parents to come. Again, being in the COVID times, and also for you being away in another country, another continent, we often do these remotely. So nowadays, it's so easy to get people on Zoom or Skype or on the phone just to make sure that they're involved. So we try to get the parents as involved as they want to be, as they can be in the process. And this is sort of a good time for us to assess also if you like the surrogate, if she likes you, if we think it's a good, psychologically, if it's a good match. So at the end of that visit, at the end of that day, we send you back to the agency. The agency will basically complete the legal arrangements, make sure that all the contracts are signed, and make sure that there's good medical insurance for the surrogate to cover her pregnancy. As soon as we get clearance from the agency, then we will schedule the embryo transfer. In other words, and I said before, usually for most couples, it takes a month or two to find an egg donor, which means that we can immediately start to create the embryos, which also means that by the time we find a surrogate, we already have the embryos frozen and waiting. So once the clinic visit is done, the contract is signed, we can immediately move on to the embryo transfer. I continue to follow the surrogate medically for the first trimester. She becomes basically my responsibility, my patient, from the time I meet her. She may not be local, she may not be in Connecticut, but even if she's not, we continue to be supervising her care. And when she gets to the end of the first trimester, we usually send her to her OB doctor to follow up. And then, Melissa can complete this, but this is sort of the agency's role in the process.
I think that, Dr. Lavy, you've done a really good job describing what we do. And the only thing that I would add is that, Dr. Lavy won't be following the carrier after the first trimester. I'm sure if you call him, he will definitely try to talk to the OB and answer any concerns that you have. But in general, it's really the agencies that are going to be taking over, monitoring you, helping you get to the United States, get your name on the birth certificate, the parentage order, complete the finances. So we're more present after. I mean, we're present the whole time, but Dr. Lavy will kind of be in the background after the first trimester.
Thank you. And the last but not least, the sperm. Of course, we can't do it without the sperm. So basically, we will make sure that we have a good idea of the sperm parameters. Your health. We do a semen analysis and make sure the sperm is okay. In all cases, we actually freeze the sperm in preparation for the procedure. We're also required, we call this the FDA testing. Essentially, it's a panel of infectious disease testing that is required to be done for both the egg and the sperm donor. So typically the way we handle the sperm is that we will essentially bring you in and provide a sample, make sure the sample is good, do all the required testing, and freeze the sample and hold it. So in other words, once the sample is given and frozen, your part is done, and then everything else we can do without you. Now, for, of course, being so far away and having all these travel restrictions, more and more now we arrange for the sperm freezing, analysis, and testing to be done locally to where you are. So depending on the country, we will find a location where you can actually go and freeze your sperm and do the testing, and then we can arrange for the sperm to be shipped to the US. So that means basically, as far as the logistics, as far as travel, theoretically at least, you can do this whole process without coming to the US. Of course, you'll need to come in to pick up the baby, but the rest of it we can do remotely. And it sounds a little strange, a little awkward, but actually it works quite well. And maybe just in 1 minute about the current COVID crisis, the pandemic, because we get many questions about this and whether it's a good time to be pregnant, is it a good time to have a baby, is there any risk to the child, any risk to the surrogate. So I think the bottom line, is the fact that we don't have a lot of data, but we have some data from the early days of the pandemic from China and through Italy and now in the US. Unfortunately, we have quite a bit of experience. So what we've learned is a few things that are not absolute, but are helpful and are reassuring in a sense. So for example, the fact that the woman is pregnant and she contracts the virus, the disease is no worse for her than it is for someone who's not pregnant. In other words, being pregnant is not one of the risk factors like obesity, high blood pressure, diabetes that make the patient sicker. The other thing that it's always really important with viral conditions is to know if the virus actually can cross the placenta during the pregnancy to the baby, and it doesn't appear to be the case. There are a few reports that maybe it does, but overall I think the consensus is that the virus doesn't cross the placenta and doesn't infect the baby in utero. And again, that's really important. I mean, for example, on the other extreme is the Zika virus, where it does cross the placenta and causes severe birth defects. So those two things are reassuring. The thing that we do know, however, that is not specific to corona, to COVID, is the fact that if a woman is in her first trimester and becomes ill, and especially if she has a high fever, there is a higher risk of a miscarriage that basically just has to do with the fact that she's sick. So again, I mean, the virus is here. It doesn't look like it's going anywhere anytime soon. So I think, my view on that was that, you have to adjust. You have to decide if you're actually willing to take any kind of a risk. But I think for most people, and especially if you follow the precautions that I listed here, uh, uh, I think you can do it with relative safety. And we're in Connecticut. Many of the surrogates that we work with come from other states. And in addition to all these things that I mentioned, there's also the travel restriction that we have to deal with. So it is a headache, and it may prolong the process somewhat. But again, if you follow all these precautions, and we are very, very clear with everyone involved, the parents, the surrogate, the egg donor, and I think you can do it safely. So I think this is the end of the presentation. We have here the contact information for Melissa and for myself, and that will be available on the website and the recording. I'll let Melissa actually say the last word.
Well, I basically just wanted to say that this is going to seem overwhelming because we gave a lot of information and it was over an hour. But realistically, you really just need to take it one step at a time. If you go to Dr. Lavy or myself, we're going to give you all the steps, and there's nothing you're going to forget. We're going to remind you what the next step is at every juncture, and we're not going to let you forget a step. So it's not like you need to save this recording and re-listen to it and write down every step of the process. That's why you have professionals. You just have to decide that this is right for you or this isn't. Pick the way you're going to do it, and then leave the rest into the professional's hands.
Perfect. Thank you so much, both Melissa and Dr. Lavy, for a presentation with lots of details and lots of information, as you've mentioned. But I can assure you, you made it very clear and very easy to understand. So thank you so much for all. For everything already. And of course, I just want to mention that we do have one more question. However, if you have any other questions now or later on, remember you can get in touch with both Melissa and Dr. Lavy, and as you see, they will be more than happy to assist you with even more details, I am sure, as well. And now let's go to the question that we got. Okay, so let's have a look. Okay, it's which assisted reproduction treatment are best for lesbian couples, and can my friend be my sperm donor?
So let me just speak of the medical side. So, and this is really true for any treatment that we offer or that we recommend. So, of course, people come to us to have a baby, and by the time they come to us, they want to have it yesterday or immediately. On the other hand, they want to obviously keep it as simple as possible. So these two things are always sort of in my mind when I talk to couples. And as I said before, for lesbian couples, there is that option of doing an insemination, which is sort of, is still considered assisted reproduction, but it's on the very low tech end of the process. What usually I recommend is that you have a simple evaluation just to make sure that everything's working, hormones and ovulation in the uterus and the fallopian tubes, and then basically decide how to conduct the treatment, whether to take some fertility drugs or just do a natural cycle and basically do the insemination. Of course, when you pick a donor, a sperm donor, it can be someone that you know, like you said, a friend. Of course, you can do that. Or it can be an anonymous donor, someone who is basically donated to the sperm bank. So the big difference, there's many differences, of course, but I think the big difference from a practical perspective is that the donors from the sperm bank have already had all their testing done and the sperm is frozen and ready to be used. If you have a friend who wants to be a donor, at least for us, we require that they go through all the screening. Of course, they have to have normal sperm, but they also have to do essentially what I just described for egg donors. They have to do the medical screening and the psychological screening. They have to have a legal contract, basically defining exactly their role. In some states, in the U.S., in some states, it requires that the donor sperm is frozen for 6 months before it can be used, and the donor actually has to be tested again. So it's a little bit more cumbersome to use a known sperm donor, but I mean, sometimes it's hard to over. I mean, it's a for some people it's really important because even though it's more difficult, the person, who they are, their personality. It's a whole different thing to have somebody who's willing to donate. So that's sort of a discussion that we have, and I think most people, if you have a friend, most people will choose to use the friend, and even though, again, like I said, it's a little bit more cumbersome to do that.
Yeah, and from a legal perspective, it has its benefits and it has its risks. It is definitely riskier in the sense that sometimes a friend can act like a dad, and there can be parental right issues. And also, you have to really look at the state law and make sure that you've complied with it so that the donor is not a dad. So you can't be a donor and a dad. So there's no quasi dad, like a sperm donor can't have the kid once a month and start paying for things, because then he might become a dad under the law. So there are a lot of legal issues that we need to discuss, but definitely it can be done in the US. We have to make sure the state law, the clinic law, and all of those aspects are done. It can be a little bit more expensive to use a friend because of the testing, which can add up sometimes. Before though that you use your friend, what I always would suggest is that you consult with Dr. Lavy, have your genetic test done and your friend's genetic test done, because if he has a rare disease or has a recessive gene that you also have that can produce a child with cystic fibrosis or Tay-Sachs, then he may be eliminated quickly. And so you just want to make sure that from a genetic perspective, he is an appropriate donor.
And make sure that he has sperm. I mean, that's important.
Definitely.
All right. Excellent. Thank you so much for your question and indeed for a thorough answer to this and explaining all aspects on this, of course, as well. And well, I guess we will be finishing. But again, let me just remind you that if you would like to get in touch with either Melissa or Dr. Lavy, you can use the link that is in the chat section, or you can simply use the information they have both provided as well. And I just want to mention that, of course, it has been recorded, so you will have a chance to watch this again. And thank you, everyone, for joining us today, for being with us, and I am sure it was very useful to you. And Melissa, Dr. Lavy, as always, it's great to have you with us, and I know it's not our last webinar, so I am already looking forward to our next one. Indeed, thank you so much. And is there anything you would like to add?
No, we hope to see lots of babies.
Yes, I hope this was helpful, because I know it's for many people it's a huge decision to make, and it's a little bit overwhelming. That especially if you need to go through more complex procedures. So I think the first step is to have a really good understanding of what's involved and to find the right team to work with.
Excellent. Thank you so much, Dr. Lavy and Melissa, of course, for that.
Thank you.
And there is someone, of course, has just added, great informative webinar. Thank you. And of course, thank you for that comment as well.
Thank you.
And well, I just want to one more time mention that you will be able to find it on myivfanswers.com, and of course all other events are available on our YouTube channel, so I can only encourage you to simply subscribe to our channel. And of course, we will be back on Monday, and slowly we'll be finishing with our Stronger Together initiative. But I do hope to see you there on Monday. And of course, have a great and relaxing weekend, everyone. Melissa, Dr. Lavy, thank you so much once more. And again, have a lovely weekend. Thank you so much.
Thank you.
Bye.
Take care.
Good day to
Bye-bye.
you as well,
Goodbye.
right?